Okay, let's get started. It should be quick. So let's go through some benign lymph node unknown. Some really difficult to find the virtual slide, so I just put an image there. So let's go through quick the normal pattern recognition of a normal lymph node. So this is the cartoon image. So talking about the normal lymph node pattern, we know this is primary follicle and secondary follicle. We also call this germinal center. And then between this follicle, we have this pericortex area. Normally this area, we have T cell. So they are usually darker because of the T cell. And then for the pattern recognition, so we have either follicular hyperplasia pattern. That means we have too many of this germinal center. And then if we have the pericortex area expansion, more of this dark area, we call this pericortical expansion pattern. And then we also have, this is capsule, and then we have subcapsular sinus. Here we usually see the metastatic carcinoma here, but here's the medullary sinus. So when we call the sinus expansion, we're talking about this medullary sinus area, and then another pattern for a benign lymph node. So and then here's the whole image for a normal lymph node. Just show you really quick, like primary germinal center and then secondary. And then between the germinal center, we have this pericortex area with T cell, and then subcapsular sinus, and then this is the medullary sinus. So, and then depends on different pattern, we have all of these diagnoses, and then today's unknown, they will fall into one of these diagnosis names. So all you need to do, you don't need to really know the diagnosis, but if you know, that will be better. But if you just can recognize, is it a follicular pattern, sinus pattern, pericortical pattern, or kind of mix, and kind of either of these two or three mixed together, and then you will have the answer. So for the first case, if you don't know the diagnosis, you can just tell me what you can see. And then so first, just any volunteer want to take this case, just tell me whether this architecture preserved or not. And then what is the pattern you can recognize in this one. And then if you know the diagnosis, that's good. If you didn't know, and then I can just go ahead and then go through it. So for the case one, anyone want to take a try? Yes, we have follicular hyperplasia, and then we also have pericortical, because usually we have this more dark zone of T cell, but right now we have some pale area, so definitely it's kind of a mixed pattern. So here's a high image, show the same thing, and then show the same thing. So this one is better. So for this is the yeah. And it looks like mixed cell pattern in this pericortex area, not just T cell. Okay, here's the money.
Your attention, please. Adult Rapid Response Team, Hospital for Advanced Medicine 7. Adult Rapid Response Team, Hospital for Advanced Medicine 7. Adult Rapid Response.
Yes, this is exactly what it is. So I think especially in the text purpose, in a really young patient, and then we have really look like rich stem cell, really like that. But you need to back up. Of course, I show you this cell is CD30 positive. So and then in this background, other than this cell, we have different kind of cell like this immunoblast. And then we also have some eosinophil and lymphocyte, plasma cell, and different kind of cell type. And then for this staining, it's really you're thinking about Hodgkin, but you need to back a little bit. As Sarah mentioned, this cell, I think, if in the test purpose, they may give you more staining. So this cell is CD30 positive, but this cell also, because this is the immunoblast phenotype, so they are CD20 positive. Of course, in Hodgkin, we have PAX5 weak, and then this cell should be strong expression of PAX5. And then CD15 should be negative. So this is the infectious mononucleosis, kind of a mimicking Hodgkin lymphoma. This cell is called a Richter-like cell. So the clinical scenario is really important, and the immunophenotype also really helpful for this kind of case. Okay, let's go to a second case. Anyone want to try to tell me whether this preserved or not, and then what kind of pattern you can see? Yes? Yeah, that's really cool thing. So we call this pericortical expansion and also nodular type. You can see kind of forming this vague nodule here. And of course, this pigment highlight here. And then pericortical expansion, not only just this dark staining T cell, they also have some different kind of cell type. So high power. Jeff, did you mention what kind of this pigment do you think? Yeah, this is a melanin. I think I have a staining. Fontana Maston staining highlight the pigment. And then these pale cells, what do you think of what kind of this cell? Yes, this is histiocyte. So do you have a diagnosis? Yes, dermatopathic lymphadenopathy. So this is another kind of a pure pericortical expansion pattern with this histiocyte. And then also this melanin pigment is really helpful when you make this diagnosis. So I think this case easy, but because this kind of thing is really easy, so in the examination they really love this kind of case. So remember this Fontana Maston can stain this melanin pigment. And then hopefully in the test they will give you a history, kind of the patient have any skin problem, rashes, or whatever they have. Okay, case 3. Anyone want to take a try to tell me what pattern of the expansion? Or I can just go ahead, it doesn't matter. So this one we can have this kind of mixed pattern. We have definitely just this one image, we can see this follicular hyperplasia, a lot of secondary photo germinal center. And then also we have some expansion between these two germinal center. And then exactly this one image almost show us what we want. So we have follicular hyperplasia, pericortex expansion, but we have this kind of pale area. Usually pale area, this is, we have two terms to describe this. One is epithelial histiocyte, this pale area. Another term we can call this granuloma, because granuloma, just like the histiocyte, just forming an aggregation. So we also can call this granuloma. And then the location of this granuloma is really characteristic. They just surround the germinal center. So epithelial histiocyte, follicular hyperplasia, and then we have some pale area. So let's go to the next one. Yeah, this is germinal center, epithelial histiocyte, and then we have some pale cells. Because surround the germinal center, we have mental zone and marginal zone here, and then go out, we do not usually see this kind of cell. This cell is called monocytoid, B cell. So they usually lymphocyte, they do not have this abundant cytoplasm like here in the mantle cell and marginal cell. And then, so this is clear cytoplasm, that is the abundant cytoplasm. And then they are actually B cells. So usually monocytoid B cell related to kind of chronic infection. So when you see monocytoid B cell, it should be related kind of infection. So this is the triad of follicle hyperplasia, epithelial histiocyte, and monocytoid B cell. And then in the background of the history, a pregnant woman. So this is toxoplasma. So this is another image to show this toxo triad. Okay, case 4. This one, the history, just 6 centimeters of white axillary mass. So in a lymph node, one of this time we do not see really definite germinal center, but we see some kind of maybe pericortex expansion, but we do not have germinal center, really difficult to tell. But this kind of thing is really characteristic, just like something necrosis. And then we have pale area. We already know pale area, usually that is the histiocyte to forming this granuloma, that this is necrotizing granuloma. So high image, we can see this histiocyte just palisaded. And then we have some kind of neutrophil and necrosis area. So even higher image to show this characteristic necrotizing granuloma pattern. And then we have neutrophil inside necrotic area. So anyone have any thought of the diagnosis of this one? Yeah, this is a cat scratch. This is by the Pathology-Li. So I put a question here. So this same kind of pattern, we have at least three differential diagnoses. So we have this similar, maybe identical morphology. But if I tell you this is a maybe 15 years old boy have right lower quadrant pain, and then they do the CT, they didn't find appendicitis, but they can find enlarged enteric lymph node, and then they do a biopsy, show something like this. And then what is your thought in this clinical scenario? Lymphogranuloma, yes, there's another scenario that should be STD, right? But I say this is a 15-year-old boy with right lower quadrant pain. Clinician thinking about appendicitis, but the CT scan do not show anything wrong with the appendix. Just show this enlarged lymph node, and then they do a biopsy. I think I should have that one here. Yes, Yersinia. That's this one in that clinical scenario. And then, yeah, Sarah is correct. So if we have a clinical scenario like an STD patient in the inguinal lymph node, that is LGV caused by the chlamydia. So that is what it is in this one. So I don't know whether this is a lymph node, but at least we can see this germinal center. So if this is a lymph node, maybe the architecture kind of preserved, so more likely a infectious disease. And then we also have this really nice granuloma with necrotizing in the middle, and then we would like to see some neutrophil and then necrotize. So this is LGV. So when you see a lymph node with this necrotizing granuloma, so in different clinical scenario, you just think about cat scratch, and then Yersinia, and then also the LGV. Of course, TB, is it TB possible? Yes. When you see granuloma, necrotizing granuloma, you always think about TB. Okay, so this one is the LGV. So, and then this case kind of a little bit difficult. Anyone want to try this one? I can do it. Oh, sure. Sarah, if we want to do, yes. Yeah, this is Kimura disease. So this lymph node is kind of preserved the architecture, so usually not malignant. If we can tell this is a lymph node, and then we can see this uh, germinal center. But of course, follicular lymphoma, we can see a lot of this germinal center. And so this is kind of another mixed pattern. We have follicular hyperplasia, and then we have this pericortex expansion. And then when we zoom in, Sarah mentioned we can find a lot of EO. So this is one of the clues when we see EO. Of course, EO is also related to other two really common diagnosis, that is the LCH, Langerhans cell histiocytosis, and also mastocytosis, and then also this Kimura disease. So we find the eosinophil, but this is really interesting about this pericortex area. We have a lot of this vessel proliferation in this pericortex area, not like the infectious mononucleosis. There were a lot of immunoblasts and mixed inflammatory cell. This one, we have a lot of this vessel. And then this endothelial cell is not like the normal vessel, because kind of fat, kind of plump, more epithelioid than the classic endothelial cell like spindle. So this is another characteristic feature of this one. So this is Kimura disease. So because we have a counterpart in the skin, when you see the skin fighting without this germinal center, but other things are the same. We have eosinophil, vascular proliferation, and then we have this plump endothelial cell, that is the ALHE, angiolymphohyperplasia with eosinophil. So this is counterparts in the skin. They show exactly the same pattern, but just without the germinal center. So this is Kimura disease. And I will go through this one because this one is kind of difficult. We even not even recognize this as a true lymph node, but we just can see it looks like something capsulated. But the feature of this is that they usually should still recognize some germinal center or other lymph node area, not like this one, just like totally almost effaced. But in this area, we also can see this pink material that is the necrotic area. But in comparison to the necrotizing granuloma pattern like the cat scratch, they also have this necrotic area. But other than this characteristic debris, you could not find neutrophil. So this is one of the feature of this kind of disease. And then this histiocyte kind of forming this question shape. So necrotizing granuloma in the lymph node without neutrophil, only characteristic debris, and then with this question shape histiocyte. So in the examination, you choose the answer is Kikuchi-Fujimoto disease. So this is what it is, the diagnosis for this one. So for the last one, I think this one is the easiest one, I think. And in exam, we have this a lot. So also low power, we have this follicular hyperplasia and also pericortical expansion, because we do not see any we only have a little bit this medullary sinus area. And then even in this power, you can appreciate that we have this onion skin pattern of the germinal center, and then we have this lollipop pattern with this hyalined vessel in the germinal center. So I think in the text purpose, they really want to show us this. But for a whole image slide, we need to more focus on this pattern pericortical pattern. Just like Kimura disease, we also have this endothelial cell proliferation as a vessel here, but we do not have eosinophil. And then this endothelial cell is not that plump. They still have this spindle cell morphology, not like the Kimura disease. So this is the vascular castleman disease. But you need to bear in your mind that hyaline vascular castleman disease is not related to HHV8. Just a multicentric castleman disease is related to HHV8. And then another two diseases related to HHV8, that is the primary effusion lymphoma and also Kaposi sarcoma. So for technical purpose, just remember these three are related to HHV8. So I think that's it. Anyone have any question about today's topic? If not, we can conclude our session. Thank you, everyone.